Thank you so much for joining us at Spotlight. I'm doing a feature series on PMDD because I've struggled with it quite a lot. It's PMDD Awareness Month, as you might know, this April.
Yeah, absolutely.
So, would you tell us a little bit more about yourself?
Yeah, of course. So I'm Tracy, Dr. Tracy King, and I'm a clinical psychologist. And as you're aware, I work holistically. I do both, actually. I work in a very evidence-based way, and I work as an expert witness, and I take insurance referrals, and I work within discrete models that are evidence-based. But in my direct practice, that when people come to me, I work very holistically for people that resonates with. And by that, I mean I will combine lots of different talking therapies. I will work somatically with the body. I'm also a yoga and meditation teacher, so I work very much in body-based movement, and I've done lots of somatic trainings, and I work with clinical hypnosis. I work with eye movement desensitization reprocessing for trauma, and my specialist area is really trauma and neurodiversity. But underpinning everything that I work with is really regulation of the nervous system and working with people and looking at whether they're overactive or underactive in the way that their nervous system is presenting to the world, understanding the narrative and the story behind that as to why it's had to develop that way, and also then working with ways that they can balance that to widen their window of tolerance to being able to cope with whatever they need to cope with or whatever goals they want to reach in their day-to-day life.
Oh, wow. That sounds really interesting and quite unique, actually. So thanks for sharing that.
Yeah.
How do you approach someone specifically with PMDD through this integrated lens then, if your clinical psychology on one side and your spiritual and somatic practices on the other side?
Yeah, absolutely. I've developed something that I call the mountain method, which is really a triangle. And it's based on, I don't know if you've heard of Maslow's hierarchy of needs, which is an idea that we need to feel safe and secure before we can move up and form relationships and move up and eventually get to self-actualization, and beyond that to transcendence and spiritual awareness. So we usually start with the physical, essentially looking at the basic needs that someone has to meet. So we're looking at, they could come with anything really, not even just PMDD, but with PMDD, because this is such a biological condition, it's looking at the body. The body is what we're actually working with, and we're looking at things like getting them to initially track their symptoms and understanding when they're coming up, because very often what I've found when I'm working with PMDD, and this may or may not be your experience too, is that it's such intense symptoms that often the nervous system will shut down and be quite detached from some of the symptoms because it's become a person's norm. And it's only when we start to talk about it that they realize how much it's impacting them beyond which they thought it was impacting them. So having an idea of what is happening for them in reality is really important. So we will look at their lifestyle, we'll look at the things that they eat. So I take a normal health and nutrition approach that I've done extra training in. I also work Ayurvedically, so within the Indian system, and looking at how your constitution is. So there's different things called doshas, which we don't really have time to go into, but we look at where somebody's dosha is at. And with PMDD, it's often a sense that there could be sometimes a bit too much pitta, which is heating up the system, or there could be a bit too much vata, which is making people feel almost disconnected, and it's making the nervous system feel quite unbalanced as well. So we will look at that and look at how that's impacting when they exercise, when they sleep, when they eat, and just thinking about lifestyle as a kind of bottom base level. And then we're looking at their nervous system and looking at whether their go-to places is going to a place of fight or flight, because with PMDD, as you'll be aware, there can be intense rage that's present, which can often come from that fight or flight. And then there can be cycles of shame that come from that, which then can lead to the nervous system shutting down. So the very first port of call that we want is for somebody to feel satiated, sleeping enough, feel that they're actually connected and safe within their body to be able to do any further work initially, is how I would start things off.
Okay. Wow, that's interesting. Have you ever had a case where your evidence-based, like clinical psychologist approach has conflicted with, your more spiritual and somatic approaches, and how do you reconcile that?
I haven't specifically, in the sense that with my spiritual and holistic ways of working, I will only go to that place if that resonates with somebody. By that, I will mean often people will come to me and say, oh, I've been for cognitive behavioral therapy, I've been for standard talking therapy, and it's really not helped me. So then I will then open up to the other approaches that I might do. So beyond what we've spoken about in terms of, there could be yoga, there could be meditation, there could be the nutrition and the Ayurvedic approaches. I also do energy healing, which is obviously not in my clinical psychology training. That's beyond that. And for some people, that can be really helpful as an add-on. And some people that have been open to that, I've worked in that way with. So I'm not coming with this is the only way to work with it, because I think I'm of a view that for anything to work, it has to have trust and it has to have buy-in. So if someone was going to come to me and they're completely not holistic and they just want the science evidence-based work, then that is most likely what's going to be really helpful for them, because that's where they feel safe. So if we're thinking about the nervous system, that's their anchor of safety, and that's what we work with. Sometimes I've worked with people that start off like that, but then they say, oh, actually I read your website and realized that you did this, and could we do a bit of that? And sometimes things evolve in that way. Or other times people have bought workshops and courses from me and they specifically want to work in this way, where we're going through it layer by layer and looking at the different energy bodies of physical health, emotional health, mental health, and spiritual health. In that way, therapeutically, it's never really clashed. When I've worked as an expert witness, I've been challenged by barristers when I've been in court giving evidence saying, oh, don't you do all this strange stuff like energy healing? But I felt that I can back that up, because I will obviously be saying, actually, I work in an evidence-based way. And when people are stuck, then we actually bring other things on board in order to actually help somebody move forward. And that seems to have worked, but there will be challenges around it.
Yeah. Oh, I really admire that. I think that's really cool. I studied forensic science and I would have never thought that those two approaches can work together, but you make it work so well together. So I really like that.
Yeah. I think it's just about flowing with what the person in front of you needs, really.
Yeah, cool.
Yeah.
You've also spoken a lot about the effect of hormonal fluctuations on things like decision making and even criminality in your latest blog post that I read. How do you think PMDD is misunderstood in both the medical and the legal context?
Yeah, I think in terms of its involvement as a diagnosis, it was often just seen as, oh, it's just a bit worse than premenstrual syndrome, but it's not. It's really understanding that it's a severe neurobiological sensitivity to normal hormonal changes. So it's not actually the changes that are the problem, it's the sensitivity to the changes, if that makes sense. So when the body is sensitive to the changes, there can be really big behavioral overreactions, and there can be what we see as enragement, and we can see impulsive reactivity that's there, because the nervous system is moving into that fight or flight quite quickly because of those reactions to the hormonal changes that are happening. And people just don't understand that. I'm in perimenopause at the moment, and I think it's very similar with perimenopause. People don't understand the degree to which that causes cognitive change. When our estrogen declines, that also declines in terms of our memory. It will make our dopamine, our reward chemical, and our motivation go down. And if we're feeling quite demotivated and low, for example, things don't feel as safe always, and then there can be reactivity that comes from that if we go into that fight or flight space. And it's understanding, like, are there patterns for somebody if they have committed a crime, for example? Are there patterns that we've seen that happen for them before the date of that crime? And is that something that's been in medical records? Is that something that's been there and it's not really been attended to? Because it's not something that's looked for. And when I do criminal expert cases, I will also always ask about menstrual cycle and the impact of menstrual cycle for people and where they're at. Are they in perimenopause? Do they have regular difficulties like PMDD that they are aware of? And if they say no, I will also ask questions around that, because it's not always something people are aware of. And I think as women, we're often taught you have periods, that's just something you've got to deal with, and it's really minimized. And I don't think the cognitive impact of these things is really considered very deeply either.
Wow. An interesting way of looking at it indeed. Yeah, and I think there's a lot of work to be done. In this kind of same vein, because in my case as well, I've felt a bit gaslit and a bit dismissed by healthcare providers. Oh, you think you've got PMDD? I'm sure it's not as bad as you say. From your kind of perspective, what needs to be changed in the way that healthcare professionals are trained to recognize and to also respond to these kinds of hormonal mental health conditions?
I think they need to be working in a trauma-informed way, because it's not just the PMDD, it's the shame that brings. So building on what I was saying before, as women, we're taught to just deal with it. You get periods, it's just a thing that happens, and you just, deal with it. It's something that often women I've worked with don't feel able to go and see a healthcare professional about necessarily, because they feel like that almost the way the system works, they're made to feel that they're overreacting, or that only happens for a little bit of time, and then I have my period, because it happens in that sort of luteal phase in the lead up, and then I have my period and then I feel better, so then I didn't bother to make an appointment and I haven't bothered to do it. I feel like it needs to be something that's almost like an outreach, and it's asked more explicitly in questions, rather than something that is left to women to self-report, because I don't think it's always as evident as we might imagine, because we hear that it can be very reactive with rage, etc., but it doesn't have to be. It can be extremely low moods for somebody, there can be suicidal thoughts for somebody, and then what will happen is they'll have these intense feelings, and then, as I say, the period will come, they'll start to dismiss it, and then they forget about it, and then it's never really put on record, and then they don't go and see anyone. And I think for that reason, that's why it's really important to, if you're doing an expert assessment in criminal law, to understand what is happening for a woman in her cycles, because of what I've just said, often they won't go to the doctors and it won't be on record, which is what legal cases will often look for, to prove that there was a problem before, when actually women won't necessarily self-report this because of the shame around it.
Yeah, that makes a lot of sense, actually. And you just touched on trauma, right? Do you see some connection between past trauma and traumatic experiences and how people experience or cope with PMDD? Does it make it worse?
Yeah, I think it's a two-pronged response to that, really. I think if someone has had trauma in their system, if we're thinking of it energetically, we can think that it holds in our energy systems, and it holds in the chakras, which are our energy wheels, and in your sacral chakra, which is where all of your sort of menstruation, etc., is held, and maybe in your root chakra, which is a sense of safety. And there can be disruption there because of the pain, because of the emotional regulation difficulties that it's bringing up, and the thinking difficulties. But there can also be difficulties for people if they've had trauma, that there'll be disruption there. And if they've had trauma, what I was talking about as the window of tolerance for those people will be a lot smaller. So then when PMD does its thing and brings all of its symptoms, the difficulty in the body will be, there'll be a lot more inflammation, there'll be a lot more stress and contraction, because the body is already in fight or flight. And then the resilience and capacity to cope with the PMDD, there's going to be extra layers of challenge on that if there's already trauma. So there's trauma there, then the PMD comes. There's an idea that energetically trauma can create conditions like PMDD and many other conditions that are very inflammatory as well, and that they're causing actual chemical differences, is an idea more in spiritual circles and metaphysical kind of interpretations. And then also the PMDD itself is traumatic. So actually having reactions where a woman feels she's not herself is extremely scary, because sometimes I've worked with women that can be very aggressive, for example, with partners, and that's not who they are at their very core. So it's something that's called ego dystonic, like it's apart from their sense of core ego, rather than ego syntonic, where somebody actually maybe wants to be aggressive or feels that it's warranted. Very often for women that I've worked with, again, I'll come back to shame, because people act in ways that they just can't make sense of, and they don't want to talk about, because it's not who they are as a person. And I think that trauma then layers there, and very often you've got the trauma of the PMD that then layers onto the inflammation in the body, that then layers onto maybe childhood trauma, that then lowers resilience right at the very beginning.
Yeah. And so what I'm hearing is there are a lot of layers, and I guess with your holistic approach, of combining the clinical psychology part maybe with medication and talk therapy, and then combining the spiritual and somatic practices on top of that can really address like all of those layers. Is that how that works?
Yeah, absolutely. It's looking at, so in an assessment, we would look at all the different impacts that the PMDD is having at the physical, emotional, mental health, and spiritual level, if spiritual resonates with someone. And by spiritual, it doesn't have to be anything, it doesn't even have to be as far as the metaphysical links that I was talking about. It can be very much about a sense of meaning, a sense of purpose for someone, which a lot more people can perhaps anchor and ground themselves into, and wouldn't necessarily label that as a spiritual aspect, but it's more about development beyond the self. So that might be what we're working with rather than anything else for people, something that again makes sense in their world. And it's about understanding where are the symptoms, where are the difficulties, and for each individual it depends on how things are presented. At the start I said we often go in at the physical level, but there has been people that I might work with more at an emotional level initially. So for example, I have ADHD. So if I'm working with someone with ADHD and PMDD, often there can be a lot of emotional dysregulation outside of the PMDD point of the month. And it can be difficult for people to be consistent in some of the strategies that they might be using. So we might be using ADHD coaching and doing things that are quite cognitive, but we also might be doing lots of emotional regulation work before we can help them to make some of the changes to their lifestyles. For example, with someone like that, we might actually do the emotional work before we do the physical work, depending on how they present.
Yeah, no, that's interesting because I just wanted to talk about this neurodivergence because there's more and more evidence from scientific research that neurodivergence and PMDD are closely linked. So you talked about how those two can intersect in terms of treatment. How have you seen the two intersect in other ways?
Yeah, so if we're talking about ADHD specifically, the way somebody with ADHD processes dopamine is different. So there isn't enough that's held in the system. And if we have spikes and drops of estrogen, which we have during our period, that can then cause less dopamine. So all of the ADHD symptoms will be worse generically as well. So again, it's layers, I think, is the sort of word of the night, really. There'll be the layers of, you've got the PMDD that's causing difficulty for somebody in their luteal phase of their cycle, and then you've got the estrogen changes that are impacting the dopamine production with the ADHD, and then you're going to get intense emotional responses that have the potential to arise with somebody that has both, that are layered in.
Okay, makes sense. Could you maybe give an example to make it a bit more concrete? Because I can't really imagine if you're already living with ADHD and have that difficulty that to also even diagnose the PMDD, like how that would present.
Yeah, absolutely. For example, I've worked with women that have a lot of sensory difficulties with ADHD, so that I don't know, I guess I can use this as an example. So I'm wearing like a sort of roll neck jumper. So I've worked with women that during the time of their period where they would get PMDD symptoms starting to come up, they wouldn't be able to have things touching them. And I've had women that have had that so severe that they've had to work from home or have time at home because they then can't wear any clothing during that time, because the sensory difficulties that are a part of the ADHD and the neurodivergence becomes even more intense during that luteal phase when the PMDD is coming in. It's an everyday occurrence in terms of the sensory issues, but it's something that has a big impact because they need to obviously wear clothes to do what they're doing, and they can't do that. I've also worked with people that are in the criminal justice system where they have been reactive and there have been assaultative actions whereby for example, they've had arguments with neighbours that they may not have reacted in that way if they didn't have both of those layers. So it's the intense emotions that I've seen are the reactivity that seems to happen when there's two layered together.
Makes sense. You also mentioned online that you work with high-performing individuals, people like actors, athletes, professionals. what unique challenges does PMDD present to people in these kinds of roles, and how do you help them maintain stability in these high pressure environments? Because I can imagine that you just described, if you were in a high pressure environment like that, that would activate your symptoms really badly. And yeah, how do you deal with that?
It's an interesting one, actually, because a lot of people that I've worked with, it's the fear of how the PMDD is going to impact that ends up being a lot larger than how it has impacted. Not all the time, but I would say people come to therapy because they know how the PMDD impacts them within the home environment. So, for example, they might be having more arguments with their partner, they may be having less patience with their children. And then they may be, if we use an example of a singer, they may have something that they're going to have to perform somewhere, and they've got to do lots of rehearsals, they've got to be in auditions, and they're forever looking at their cycle and thinking, oh, okay, this is that day, this is this period of time, so I know that this is going to be quite a risky time. And they fear it, so the anxiety is very present. And for some, it has meant that they lose auditions. For some, it has meant that they've not taken jobs. For others, they've battled through it, but they've always had that cloud of anxiety that's there, thinking that there's going to be some moment of reactivity. And then for others, they have, for example, been quite reactive to choreographers or people that they are performing and that are like directors, etc. And then there's difficulties that they have interpersonally as a result of that. And a lot of the women, again coming back to shame, are very shameful about sharing with anyone. That's what the difficulty is. And a lot of the work that we do is working through a narrative of what does that mean to them if they have something like that. Is that a weakness in their mind? Have they got what we might call a be strong driver, where they feel they have to cope with everything? And what are the fears of judgment if they actually share that this is a biological condition that they are working with, and these are the consequences of it? So we're working through building a lot of self-compassion. We're working through acceptance of where they're at with the condition, and what's the narrative that they have around it, and how are they going to explain it to other people. And what I tend to find is once they've actually told people that they have this condition and this is how they might be during that period of time, a lot of the anxiety backs off, and actually the nervous system is a lot calmer. So the types of symptoms with the PMDD that they might have had at home are not presenting so much in that working or performing environment.
Okay. Oh,
Mm.
interesting.
Mm.
And this is my last question, by the way. If you could design the ideal support system for someone with PMDD, like from healthcare and official healthcare channels to coping strategies that they can apply, like you just mentioned, in their daily life, like increasing their resilience, what would that look like for you?
I think if we were going to think about in the UK, the NHS, I think it's got to be a multidisciplinary approach, because I don't think people are necessarily going to present with lots of different trainings as I do to be able to, as a one-stop shop, be able to offer holistic approaches in that way. So I feel that there needs to be interaction between services. The first thing that I mentioned earlier was having a way that women are invited to talk about their monthly cycles in much more depth than ever happens, in my experience anyway, and in the clients who I see. They're not, when they go to the GP with a certain symptom, they're not really asked, or there is no exploratory time to be able to speak about that. So maybe having menstrual clinics or having drop-ins where people can actually go and talk about what's happening for them and the impact that has on them, with people that are trained to understand the different ways that the monthly cycle can present and the difficulties that certain things can bring, and specifically with conditions like PMDD as well. And I think perimenopause is getting much more of a focus on it, not enough yet, I don't think, but I think perimenopause, menopause is actually being seen much more as in a much more focused way. And I do a lot of work-based needs assessments where I work with employers to understand how somebody with perimenopause might be presenting and how that might impact their performance and adaptations they have to make. And I think things like PMDD, that needs to be out there a whole lot more as well.
Yeah, that's a really nice perspective on that. Hope we
Yeah.
can work towards it.
Yeah, absolutely. And I think it's education really, and having as I said, that layer, that multidisciplinary layer, it starts maybe with the GP, because that might be the first place that someone goes if there's difficulties. And then it's maybe going to some sort of drop-in clinic, but having people like dietitians there, having people that do some yoga there, having movement meditation and nutrition and exercise of some description, as well as people that are working with thoughts and feelings.
Yeah, it's just acknowledging it as well. I've talked to a few people now since I've come out as a PMDD sufferer, let's say, and just that response of, oh, I've also been struggling with things like that, or, oh, I can't believe you've had this, and let's talk about it, kind of thing. That's really helped. Maybe even having a community of people who understand what you're going through can help.
Absolutely. And I think it's one of the things I said towards the start was I see lots of women often in criminal justice situations that don't necessarily know that PMDD might be an issue for them, but when you actually talk to them and you hear the trajectory of different symptoms and what they've actually been experiencing, that becomes a real reality. And there's a big thing for women to just accept what's happening, because that's just what your body does, which I referred to a few times, because I think that's something that actually women need educating and helping to be able to step forward and say, actually, yeah, my body is doing this, but this isn't okay. Something different is happening here for me.
Yeah, makes a lot of sense.
Yeah.
That was it for my questions. Do you have anything else you'd like to add?
No, I guess I would ask the question, as someone with PMDD, what do you think you would like in terms of services? Because that's always good for me as a practitioner to hear, because that will help me to think about things too.
Yeah, first of all, for people to be aware, because I have presented with PMDD symptoms since puberty, but no one around me recognized it, not my parents, not friends, not anyone, not doctors. I went through counseling and through psychological help a few times as well. I studied in the UK, so I went to NHS. I got counseling because I had a lot of trouble. I had self-harm issues and things like that. But no one ever asked me if it might be a regular occurrence, or no one thought to make the link between that and my menstrual cycle. So I think that kind of awareness, that understanding will be a great starting point. And once that's been brought into the picture, I think from there you can really do so much, because then it's been recognized. So like that would already help, because I was always thinking, like, is there something wrong with me? Am I depressed? But I'm not usually depressed. It's just sometimes I get really confused. And it's just within the last few years, like I think maybe 5 years or so, that I really recognized that this might be linked to my menstrual cycle. And even then, I was like you said, I should probably just deal with it. So I'm a bit grumpy and I'm a bit weirder during that phase, but maybe everyone has that, or no one's talking about it. So it would be great to have people to talk to about it, because no one around me, none of the women around me have this issue. Like I've asked people, and my mom doesn't understand it, and my mother-in-law and I do, my friends, and they're all like, wow, that's really strange. I can't imagine what that must be like. So that makes you feel really alone. And I think having a group of women to talk to about that would be very helpful, and we could exchange coping strategies and that sort of stuff, and get referred to healthcare providers, and everything would just be a little bit easier.
Yeah, absolutely. No, I think so too. And you mentioned about medical gaslighting earlier, but I think almost I've seen women that can gaslight themselves, whereas you can have that huge spike of feeling really suicidal, and then that goes. So then someone will say, oh, it couldn't have been that bad. I don't need to see anyone about that. It's gone now. And then it happens again, and you get this kind of graph that's going like that.
Yeah.
And then almost a bit like things like childbirth, it's really painful when it happens, but then your system makes you forget, and it can happen again, but then it means that it doesn't prompt you enough to go and take action. So it's about having that external support, that external system around us that permission gives to seek the appropriate help, I think is really important.
Yeah, and I think it's also difficult, because one time I remember about 3 years ago, I think I went to see my GP about it. I was like, I think there might be something wrong with the luteal phase of my cycle, because I feel really bad and I have all these strange thoughts and I don't think it's normal. And he was like, how about you see our in-house counselor first? And she was a little bit like, oh, let's try, have you tried homeotherapy and have you tried this kind of stuff? And I wasn't really convinced that she knew what I was struggling with. So that was difficult. And then after that, I had this kind of thing where I was like, oh, maybe it's not, you know, maybe I shouldn't see a GP about this. Like maybe they don't know. And so that kind of put me off going again because it's had that experience of not really being believed and being dismissed like that. And then this time when I went, I brought my partner. And at first, the GP was a bit skeptical. She said, oh, are you sure? Are you sure it's not just PMS or whatever? And then my partner just started describing like how we've been having a lot of fights and how it's really been impacting our relationship. And that was a point where she was like, oh, maybe this is really bad. If it's impacting a relationship, it must be really bad. And I was like, why is it that when I tell you how bad it is, it's not that bad? But when my partner, a man, starts talking about how it's impacting his well-being and like our relationship together, that is, oh, maybe there's a problem here. That's not how it's supposed to be.
And if you think of that, what's happening, coming back to my layers, is what's happening is PMD takes away a sense of autonomy with your own body because this thing takes over you. And what you're explaining there is the doctor took away your autonomy. It was given to another man to describe what was happening. Going back to the whole trauma formulation, it's all of those experiences. It's not just the symptoms, it's the reporting of the symptoms. It's how people respond to you. Those are all layers of trauma as well, because the dismissal, the gaslighting, the sense of having no autonomy, that's all there.
Yeah, makes sense. Yeah, so that was a little bit of my journey, but we're soldiering on.
Well done to you for actually talking about it and getting something out there in the magazine and feeling able to do that. That's not an easy feat.
Thank you. Thanks a lot. And thank you so much for your work. And also today for taking the time to talk about it. Yeah.
Yeah, it's lovely to talk to you.
Yeah, it's been really nice.
Lovely. Thank you. Well, lovely to talk to you.
Thank you.